Yes, it is true that the skincare product that you're using can actually bring you problems, especially if your body is hairy. Did you know about this condition, the one we call Dcpa? It is what we call Dermatitis Cruris Pustulosa et Atrophicans. And Dr. Abraham from E&E Dermatology, I'll be taking you through a quick review of this condition that we commonly see in patients. So in the picture here, as we start, you will note that we have a first picture. Our first picture is showing a leg of a lady with these pustules, with this skin atrophy and hair loss. You see in this area, we don't have any visible hairs. And the second picture is showing us an animation, someone with hairless skin. And the last one is showing us a skincare product, which is in form of a jelly. So all these three things are connected and you are going to see how. So the first one, this condition, the one we call Dcpa with actually if I treat it as Dcpa, but the full name is Dermatitis Cruris Pustulosa et Atrophicans. Dermatitis just means inflammation of skin. Cruris, we know the cruris, this is the origin of the leg. And then pustulosa, this comes from pustules. Et atrophicans, this just means atrophic skin or thinning of the epidermis. That's what we call atrophy. So Dcpa is a chronic skin disorder which usually affects the legs, primarily characterized by pustules, scarring, and then skin atrophy. It was first described actually here on our continent in Nigeria by a colleague called Clark in the 1952 after observing these rashes on legs of very many women. So as we can see in this picture, this is a patient we had at our clinic. And when you look at this leg, if I'm to do a close-up and then if I'm to magnify for you, you will see that we have pustules, we have papules. This is a pustule, that is a papule, all the way diffuse, and they're symmetrical on both legs. So you may keep wondering what is going on here and how do I manage this. So this is why you are attending this lecture. So this CPA is one of the condition that we actually, up to now, we don't know what is causing it, what is the exact cause. However, the lines of thought that different people have published, they think that the following play a role. The first one, a chronic infection by bacteria, because of the pustules that we see. People are thinking that maybe it is Staph aureus or Staphylococcus that causes the chronic infection or the folliculitis that we see. Then we also think that it is environmental factors, including poor hygiene, humidity, because it is very common in our setting in the sub-Saharan Africa, in the tropics and the subtropical areas. And then possibly it has also been linked to chronic venous insufficiency and then lymphatic obstruction disorders. And there's a thought that maybe autoimmune factors also play a role. Maybe there's also skin barrier dysfunction. However, it has also been seen that maybe the hypergammaglobulinemia also plays a role. But all these factors have not yet been confirmed, which and how exactly the disease process occurs. So that's why you're having this little lady here wondering what brings about this CPA. So when you go to epidemiology, how common is this condition? Usually, for age, usually affects the middle-aged individuals and also the elderly, but more common in males compared to females, with a geographical prevalence being higher in the tropics and the subtropical regions. That is especially Africa. If you can see this belt here, that belt, that pink belt, that is where our Uganda lies, and we are in that region. So the risk factors that have been identified include hairless skin. That is one. That's why in the first picture, we saw an animation with hairless skin. Then two, occlusive dressing and skincare products, including use of jellies and oils. These factors, at least for them, have been confirmed to be associated or strongly associated with the CPA. The prevalence is about 0.4 to 4.8%. So in the clinical picture of DCPA, usually we have pustules, we can have abscesses, we can have this progressing to fibrosis, scarring, and then skin atrophy. And later on, some patients can even develop chronic leg ulcers. That's why it has been associated with chronic venous insufficiency. Still, the skin will appear shiny and discolored, as you can see in that picture. And this is the clinical picture that was described by Camela et al. And the colleagues. They thought that these are the key features that we see in DCPA, including pustular folliculitis, we have pruritus, though some patients report actually pain, more pain and itching. And then we have cutaneous edema. That's why you saw in our picture that they had swollen legs. And then we have a roughness in the involved areas. Then we have scar formation, which usually comes with loss of skin markings and thinning of the epidermis. Then the skin becomes shiny on the surface. And then you have hair loss that we call alopecia. And you can have either post-inflammatory hyperpigmentation or even hypopigmentation, or you can even have both, and in that case we would call it dyspigmentation. And in most cases it is symmetrical, either involving both legs or even both upper limbs. That is usually the forearms. So Sugarson tried to classify DCPA and even Kamal et al., but the common classification we use that is a little bit more adapted is a Sugarson. And in this case, according to him and the colleagues, they graded it into 4 steps, whereby in step 1 or grade 1, you'll have mainly follicular pustules. So you start with pustules, which are well defined, and you have that follicular erythema. And then in 2, you have now the pustules, but significantly, then you start to get infiltrated papules around broken hairs. Then in 3, you have the scaly papules with a few scattered pustules. Now, pustules tend now to move more at the periphery, at the sides, at the edges of the folliculitis, whereby at the center you have more papules and the hair loss and skin atrophy, but outside you can have a few pustules. Then in stage 4, you have almost complete alopecia because all the hairs have gone. Now the leg will look shiny and scaly, and you cannot see pustules anymore. And then you can only see discrete papules at the periphery. So you start with pustules, then you go to papules, then you go to nothing. Or we just go to what? To scaling, skin atrophy, and hair loss. So when you look at the pathogenesis, the etiopathogenesis is still not clear. We still think it's multifactorial. We've seen even in the etiology being attributed to either infections with staph and strep, climate, because it is common in the tropics and subtropics areas, and occlusive skincare products like jellies and oils, or even occlusive dressing like tight panties and leggings, or even trauma, and then also chemical injury to the skin. So these are thinking that the initial lesions are caused by bacterial infection, which leads to this chronic inflammation. And in this case, they are also thinking that the chronic immune response is the one that is responsible for destruction of the tissues, including the hair follicles and the eventual fibrosis and the skin atrophy that is seen in DCPA. So poor lymphatic drainage and venous insufficiency, usually if present, they can end up exacerbating the disease, especially in patients who have actually primary lymphedema. If they're also having hairy body, then they use ochrosylpathlin, that increases their chances of developing DCPA. So on histology, this is how it will look like. You'll see hyperkeratosis and epidermal thinning with pustules and then lymphocytic infiltrate. So later on, you see now fibrosis in the dermis and loss of elastic tissue. So in this case, this is the hair follicle. This is the hair follicle, and then you can see this dense lymphocytic infiltrate within the dermis with this or how you can say marked lymphocytic infiltrate. And if you took a layer on top. Let me see here. So this is now still here. This is the hair follicle with a plug inside. And okay, at least those are the features that we shall see. But remember, we have thinning of the epidermis, then we have fibrosis in the dermis, then we have folliculitis around the hair follicle with lymphocytic infiltrates. So in terms of treatment, since there's a thought that it has some bacterial component, we usually give antibiotic therapy, which can either be both topical and systemic. And in our clinic, we've seen patients improving on topical mupirocin and then doxycycline. But other drugs that can be given include even cephalexin, but in our case, a little bit more expensive, so doxy offers a cheaper alternative. Then we have to do wound care in case the patient has ulcers. You can dry the wound with astringents like pink potassium permanganate, GV paint, and then you apply a topical antibiotic. Then we usually add on anti-inflammatory drug because we've seen it being an immune dysregulation condition, so you can add a topical corticosteroid, but this is usually for a short period of time, and then you stop it. Then you can also give retinoids. So now retinoids, we know that they're very good. They have comedonlytic properties. So in case where you have this follicular accentuation, the roughness, they can help you to deal with that roughness, and it is part of the treatment that we usually give. And in terms of prevention, we've been advising our patients to stop any occlusive dressing or skincare product. That means that we stop anything that has jelly or oil, and then they stop putting on things like tight stockings, tight leggings, or even panties that usually occlude the hair follicle to exacerbate the condition. And with all these measures, we've seen good improvement. So once again, thank you very much for attending to this short lecture of Dcpa. And in summary, remember Dcpa is Dermatitis Cruris Pustulosa Atrophicans, very common in Africa, very common in patients with hairy skin or even primary lymphedema, and also very common in those that use occlusive dressings and clothes. Thank you very much. I'm Dr. Abraham from ENT Dermatology Specialist. Please remember to share with your colleagues, comment and like, and then you can tell us what you want to learn about in our next video. Thank you very much. God bless you.